Hello, and welcome to the Melbourne Athletic Development Podcast. Today, we are very lucky to be joined by Dr. Matt King. Matt, can you tell us a little bit about who you are and what you do?
Not a problem. Thanks for that, John. So, my name is Matt. I'm a physio by background, and I'm currently a lecturer and postdoc here at Lateral University. Split my time between the Latrobe Sport and Exercise Medicine Research Centre and also the discipline of physio. I have been a physio for the past 10 years, worked clinically predominantly in private practice in and around rugby and football specifically, but have also done some work with regards to some clinical consultancy, and I was a member of the clinical panel at the TAC for 4 years.
Is that through your connections with Paul Coburn and Tanya Vazari?
Well, no, I got it through an open tender, but yes, I think
Sounds like it was
knowing
open.
them, I think knowing them helped me prepare for my interview, which was good. So I thoroughly enjoyed my time. But I think, like most physios, when you start out, you do multiple jobs and multiple things at once, and then it was time for me to just start to I suppose reevaluate and concentrate my efforts on one thing at a time as opposed to having 3 jobs at once.
Yeah, okay. So a lot of your research you've done is on looking at hip mechanics, looking at risk factors associated with hip and groin pain, and thinking about things, how tissue capacity and specifically strength fit into the potential development of hip and groin pain.
Mm-hmm.
What have you identified through your research that are significant modulators for developing hip pain or pathology?
Yeah, so there's a few, so hip pain and pathology, there's a few different, I suppose, points to that. So firstly, I think the main point and the main thing that my research kind of sits around is, number one, specifically, especially in the hip and groin space, and especially in the biomechanics and movement space, research is heavily dominated by male only or male dominant cohorts.
Are these predominantly athletic populations, or?
Yes, so in the biomechanics space, believe it or not, it's actually more in a post-surgical population.
Okay.
They're often recruited, via hospitals, surgical inpatient clinics, people seeking care for their condition or for their presentation. But definitely in the sports space, it's definitely more dominated towards male participants and outcomes, and that's where most subsequent, I suppose, treatment recommendations have come from. My initial primary area of research was actually looking at, does being male or female actually matter in your presentation of hip and groin pain and potentially its subsequent development?
And does it?
And it does. So,
so what does that tell us straight away in terms of is there a particular sex that has more prevalence of hip or groin pain? And if so, what factors do you think are associated with that?
So from a prevalence perspective, from a sporting perspective, it's hard to tell because, again, all the prevalence data is done in men and particularly soccer. I will say that when it comes to, say, femoral acetabular impingement syndrome or FAI, that research is dominated by male participants, but women make up 50% of the surgical presentations for treatment for the condition. So although that's not a true prevalence data itself, but individuals that are presenting for surgery for it, half are men and half are women, but we don't have outcomes associated with women that much. Yep, you're about to say something.
Yeah. Well, based on the research you have done in like male participants at least, what are some of those findings you found that seem to be correlated to the developmental prevalence of hip pain or pathology?
Yeah, so male participants. So my research particularly looks at athletic populations and not the pre-surgical population from a biomech perspective, because that's a bit of a hole that was there, and it looks at men and women. So there's a few key things that I suppose popped up. Individuals that present with hip and groin pain but are still actively playing sport present with similar impairments from a biomechanics perspective and a loading perspective to people with hip osteoarthritis. They're just significantly smaller. And the other, from a sex-specific comparison as well, men, at least with hip and groin pain that are presenting that are still playing sports, sorry, they will kind of modify their hip mechanics and modify their pelvis mechanics. However, women modify or manipulate their knee and ankle biomechanics more so than the hip biomechanics. One example of that is, for example, women with hip and groin pain, when they're landing from a lab environment, we do a drop jump, but landing on a single leg, they actually redistribute load away from their hip and move it elsewhere in their lower limb, and actually predominantly send it towards their ankle, which doesn't actually happen in men specifically.
What do you think that does for, one, the progression of that groin or hip pain, and two, the development of other sort of injuries across that chain?
So first half of the question was around development. What we don't know at the minute, because the stuff we've done at the minute is just cross-sectional, but we're looking at it longitudinally, is the cause and effect. So are women doing it, are women with hip and groin pain transitioning load away from their hip and moving it elsewhere because they're painful, or are the ones that transition their load away from their hip more likely to be painful? The good news is we are currently looking at that. We've been following this cohort for the last 5 years, and all being well, our 2-year data will come out later on this year with regards to their longitudinal outcomes. It's, just anecdotally and throwing ideas out there, it's probably a little bit of a combination of both. What we are seeing the minute, looking at these, some research that we're doing at the minute, is these individuals that have hip and groin pain but don't necessarily have an acute event, so this sort of insidious onset pain, they're predominantly underloading when they're performing tasks, particularly walking, and there is a relationship between that underloading and how much, I suppose, the presence of cartilage defects in their hip joint as well. Now, again, we don't know underloaders ending up with more cartilage defects, or do people that have more cartilage defects underload? But again, hopefully over the next 12 months, we can start to delve into that. So that was some data that I presented recently in Denmark, which was good fun.
Do you think that has, or these associations are similar to the presentations? I know that there's a lot of research coming out of your team at Latrobe looking into ACL injuries in the female population. Do you think that these kind of similar findings are going to elucidate similar patterns across different joint structures in female populations specifically?
The interesting thing with the ACL data is, the thing that's kind of separates our hip and groin research from our ACL data is the ACL cohorts and the ACL research is there's a significant event. So there's a massive increase in load or stress that subsequently causes that injury, and then potentially it is that chronic underloading as a result that may potentially may potentially cause that to progress. There's some really good work done by Anthony Shack, who is the Richmond physio, and also Prasanna Sritharan, our engineer here, that's specifically looking at that modelling and underloading in the knee joint after different knee injuries. But I think that it's hard to compare because the instigation of the event is probably a little bit different. There's in this hip and groin cohort, there's not that acute injury that happens that subsequently causes this cascade of events that go down the track.
In terms of the actual changes that you do see at the hip, knee, and ankle, what are the differences we're seeing in male and female? I know you said that they tend to distribute away from the hip.
Yep.
With the men, for instance, when you say they change movement at the hip, what do they do? And then what do the females do that's different to that?
Yep. So women will, landing, women redistribute their load away from their hip towards their ankle. They also change their knee mechanics during walking. they take their knee through less range when they're walking. With regards to the men, they're actually, during walking, they actually manipulate their pelvis position, and they actually rotate their pelvis. They don't take their pelvis through as much range when they walk. Now, again, which came first, the chicken or the egg? It's hard to say. But interestingly enough, that's in walking. When we go to look at running, who my colleague predominantly looked at here, when we looked at them from a sex split perspective, there's actually no impairments between the cohorts of the women with pain and the women without pain, and the men with pain and the men without pain, with regards to their running biomechanics, which was quite interesting. We thought that running, it was a higher load than walking, and that may elicit greater impairments, which is actually something that we didn't see. Which we could sit here and talk about potentially why that is or why that's not the case. But I think that one of the main drivers is these participants didn't have time loss injuries. So these are individuals that had hip and groin pain that were still actively playing football, soccer or Australian football, and thus they may not have been potentially deconditioned, associated with individuals that have hip and groin pain and then subsequently end up with a time loss injury.
Do you think that has anything to do with the performance requirements of running probably limits down the variability that you can have to actually achieve a performance, versus in walking, you can kind of walk like a goofball if you want to, and it's not going to really limit your ability to get from here to there?
Probably, but then also from a research perspective, from a study perspective, and be able to see that at a lab, it's probably a little bit the other way as well. People walk, most people walk with very specific and constrained movement patterns, at least in a healthy population and people that are still playing sport. Whereas running, multiple people will adopt different types of strategies to get from A to B, and that will increase the variability in the data, and that more variability can make it more difficult to pick up impairments. So it's probably both a yes, and then the other way around from a research perspective as well.
I'm like, based on some of the work that you're doing, I'm very heavily reminded of Enda King's work out of Ireland, and the profiling they did. Have you guys found a similar thing where there are certain sort of profiles or pigeonholes that you can put certain movement types into?
Yeah, so actually, we're talking about this a couple of months ago about doing a similar sort of thing that Enda has done with his large cohort. For listeners that aren't aware of the research,
they can go look it up, Matt.
Yeah, okay, that's true. But basically, these guys in Ireland took a whole bunch of rugby players with hip and groin pain and looked at their biomechanics and categorised them into 3 different movement patterns. So we have not done that yet down here, but we certainly are looking to do it as well, because they had a cutting task. We have a straight line task. Ours, theirs is probably more groin related presentations, whereas there's more hip. So it'll be interesting to see the comparison between the two.
I was just going to ask, like, based on that, do you think that with further subgrouping, you may actually start to see some correlation between certain biomechanical patterns and hip pains? Is that it's not usually just one or the other, that actually might be potentially multiple subgroups?
Yes, yeah, most likely. Some things will be relevant for some people, but it may not be relevant for everyone. So yeah, potentially yes. And we have large numbers in our cohort to be able to do it and actually delve down into it, which is good, because you do need a substantive amount of people in order to pull that sort of modelling off.
How does the association between, say, strength parameters around the hip combine to give you some of the observations that you're getting biomechanically?
Yeah, that's a very good question.
It was Jack's question.
Yeah, it's good. And I'm going to answer it 2 different ways. The first way I'm going to answer it is cross-sectionally, it is difficult to do. However, we have just finished collecting data on another bunch of individuals with hip and groin pain and FAI after an intervention. So we collected biomechanics data as associated with the Physio First study that we're doing. So we are subsequently going to then take that and look at what strengths and what movements mediate the changes from A to B, or pre-intervention to post-intervention. With regards to some of the stuff they've done, there are some small relationships around hip strength and running biomechanics, but they are relatively small, and whether or not they are clinically significant is difficult to say, at least from a cross-sectional perspective. The real, I suppose, impactful and I suppose for the listeners, the clinical data is, if you rehab someone and increase their strength, what subsequent biomech changes will they have? And I don't know, maybe that's podcast 2 in 12 months' time.
Well, I think there's complexity to this, because sometimes you may see some direct transfer of improving or building some tissue capacity and seeing a change in their biomechanics, or maybe that development in tissue capacity then provides them with the tools needed to be able to change their biomechanics with that skill acquisition. I think there's probably, again, comes into that subgrouping of what's the actual pattern that you're seeing in the individual. And that's, I guess, sometimes hard to capture in like a big group cohort study.
Yeah, so there has been some stuff done in the States. So Cara Lewis in her lab, she's based at Boston, looking at particularly around push-off and toe-off phases of walking and running, and what happens to the hip if you increase push-off or you don't increase or you reduce it, particularly around calf strength and power, and which makes logical sense. But if you push off harder during walking at toe off with your calf, you generally are going to start reducing your hip loads as that, because you're not going to need as much hip flexor to basically pull your leg all the way through if you've got that momentum off the ground.
One of the things that I really enjoy about this, I don't know if Jack's giving you too much background of my clinical and sports performance stuff, but I'm a track coach and I coach at quite a high level. So as a clinician as well, the fact that more and more biomechanical research seems to be shifting into this clinical space, to me, is very interesting, and it's exciting. Do you currently think that a lot of clinicians actually have the understanding of, one, collecting some of this information, 2, interpret, and then 3, being able to actually put in place interventions that, if something is being driven from a biomechanical standpoint, that they can make significant clinical change?
Yeah. So to be able to measure it in a clinical setting is difficult. Like, we have a large 3-dimensional motion capture lab here that allows us to really get, I suppose, best practice biomechanics data. In saying that, over the last 12 months, there's been some very good advances in modeling and AI. As well. Obviously, everyone knows about ChatGTP, but there's a group from Stanford that basically built this musculoskeletal modeling program that most biomechanists use, and they've actually now come out with something called OpenCap. Plug for the guys at Stanford. It's great. It's free. It's a free system. You only need 2 iPads or 2 iPhones to run it. And it's an AI model that you record from 2 separate planes, and it will spit out joint kinematics and kinetics from a clinical setting. So this year we will start playing with that as well, to try and help us translate some of our biomech stuff that we can take from the lab to make it more applicable, especially from an assessment perspective, in the clinic.
Do you think that's where it's mostly going to go? Having that accessibility seems to be the thing that's driving. Even we're noticing a lot of people out in clinic land are very heavily using a lot more technology. Obviously, companies like Veld have become really popular now. The thing that I think you see is some people using it extremely well. Some people, I don't know that they even know what they're measuring, but they're measuring it anyway. That seems to be the big gap in my mind, is, are people able to use what they capture, even if what they capture is accurate?
Yep. So I think the accuracy is getting a lot better. Open cap, things like IMUs, like inertial sensors and things like that. But this isn't a physio. This is a little bit of a cynic in me. This isn't a physio specific comment. This happens in every profession. I agree. There are going to be people that use it very, very well and use it sparingly, and when it is indicated to use it, and there will be people that subsequently use it as an upsell and a gimmick. And I think that's part and parcel of attempting to also for individuals to try and capture market share around attracting patients to their clinic as well. I don't know what the answer is. I don't own a clinic, so it's probably we'll probably sit there and go, what would I know? Which is probably also a fair point as well. But I think if it is something you are interested in and want to use, it can be used very efficiently, even if you're only using a small amount of its functionality. Just because you have something doesn't mean you need to use it for everything. And maybe if people start experimenting with open cap from a clinical setting, for running assessments, maybe starting with those small level metrics and just looking at peak hip flexion and extension and cadence and step rates and stride lengths, and start to use that in your clinical assessment and also your outcome assessment, and then start to delve into, as individuals' knowledge gets better, into using some of its more high-tech features.
Yeah, I think part of that then too is also thinking about whatever pattern that person has, how is that relevant to their presentation? Because naturally you're going to get a certain bandwidth of how someone moves through space, but then also too of making sure that you have some type of model of what is optimal mechanics and two. Because I feel like in that situation, getting caught up in only one parameter, you may miss the overall bigger picture of how that person moves, and thinking of, and again, it's also that sequence of effects of what's driving what. Do you see a reduction, or do you see a impact on their overstriding, for instance, because of the fact that they have poor kinetics? Or this is where you sort of really open up to think of what's actually driving what.
And I am a large supporter of always do the thing that gives you the best bang for buck. And this isn't, and I felt guilty of this when I was a young clinician, especially for like anterior knee pain. I'd always go like frontal plane. Let's change frontal plane kinematics during landing or running or something like that. And I actually was talking to Christian Barton one day, and he made a very valid point. It's like, you're changing frontal plane mechanics by a couple of degrees. Like, why not start in the sagittal plane where they move through a large amount of range and you've got more scope to make a change? And I suppose that's sat in the back of my head ever since then. And now when I talk to people, I'm like, a little bit of something is always a hell of a lot better than a lot of nothing at all. So if you're struggling to get buy-in with people, just pick the one thing that will give you the best buy-in and the best bang for buck to start with, and slowly work up from there. It was a bit philosophical there, sorry.
No, it's good.
Actually, a question I wanted to ask you, which is thinking about diagnoses or labels that we use for hip and groin pain now, because a lot of the consensus articles coming out now, instead of referring to hip pain as being related to like femoroacetabular impingement or like adductor tendinopathy, they use much more generic terms: hip-related groin pain, adductor-related groin pain.
Yep.
Yeah. Why is that? Why are we moving towards using these more generic types of terms for overuse type of groin or hip pain?
So there's probably two parts to it. The first one is, especially in the hip and groin space, it is to reduce variability in one, communication, two, research, three, diagnostic criteria, so people can start to, both from a research perspective, pull things together, but also if a clinician wants to look up things around groin pain, they don't have to look up adductor tendinopathy, groin pain, athletic pubalgia, osteitis pubis, like all these different.
The list goes on. Yeah.
Oh, the list goes on and on and on. So it's just about more so getting some key messages around potential symptom sources to try and make it a little bit easier for everyone, researcher and clinician alike, to try and classify some of those conditions. However, you will also notice that there's also a large amount of consensus statements that do come out and have come out over the past 6 or 7 years. I can't really talk. I'm on some of them, but a running joke that we have is, when are we going to have a consensus statement of consensus statements? It's a really good process around collating all the evidence with a large group of individuals and appraising that evidence, and giving clinicians the key messages from that giant pool. And some consensus statements are done very well, but there's also some consensus statements that probably aren't done that well. And I'm not going to provide examples, so don't ask.
Can you give us an example?
No. But it's about, I suppose, collating that information and giving digestible pieces of information around whether or not it be assessment recommendations, treatment recommendations, current impairments, terminology as well.
Yeah, the reason why I ask is, when I read those consensus papers, it makes me think of, particularly in these types of presentations where it's typically a gradual or insidious onset, is the specific diagnosis, how important that is for the management of it. Because we could get really caught up in the nuance of thinking, like, is it tendon pain, and is it at the emphasis, or is it more in the actual mid portion? Is it some type of hernia? And there's all these different subclassifications of hernias. Is it more important to be able to identify, okay, maybe it is inguinal related pain, and in that situation, perhaps it needs maybe specific medical or surgical management, or is it more specific adductor related or hip related or pubic related pain? We've got that diagnosis out of the way, but more importantly, well, why? Why does that person presented with pain in the first place?
Yeah. And multiple people will present with multiple entities as well, which is difficult. Yeah. I think it's a catch-22. So you obviously have some patients that, in their mind, will hang their hat on wanting a diagnosis. There will be some people that want a specific diagnosis, whereas there will be other individuals that that may not be so much of an issue for. They just want to get better. I guess me personally, and this is again another real philosophical comment, when I started doing physio, I got super technical super quickly, and really delved into all these different symptom sources and where they were and what that meant. But fundamentally, for the majority of people, from a rehab perspective, if you calm down their aggravating factors and build them back up and give them some tissue capacity and their ability to do things through physical activity and rehab, that'll get you most of the way there, regardless of whether or not it's predominantly 60% pubic related and 40% adductor related. There are certain things you don't want to miss. You don't want to, miss a raging inguinal hernia, and things that do need that, acute medical management. But there's always exceptions to the rule. But sometimes I think simple is just a little bit best place to start.
Yeah,
I don't know if that actually answered your question. Sorry.
No, it does. But I often think, particularly in the hip groin region, just from an anatomical standpoint,
there's a lot going on.
And you've got a lot of different myofascial planes going through it, and it almost seems like a lot of these entities, perhaps the differences has just got to do with where is the weakest point in that individual. Is it in the adductor portion? Is it in the pubic portion? Is it more related to how they actually move through the hip? But ultimately, it comes back to some of the the basic principles of, do they have particular biomechanical patterns that influence or expose them to high forces, or potentially actually underloading in that particular region that's generating that pain. And then tied in with that is, how is their tissue capacity influencing the biomechanical patterns and loading that's going through that region.
And I think the hip and groin pain, especially in Australia, is interesting, because I think as a profession in Australia especially, we got real glute dominant real quickly. Everything always came down to the glutes. The poor little adductors that are massive kind of got left on the wayside. The adductors are important muscle group for strength and power. So just don't neglect the adductors.
Why do you think that is? Why do you think?
I don't know. Oh,
that's been.
I'm not answering that question.
Well,
next.
One other question. We'll come back to that. But one other question I wanted to ask about the hip and groin.
I don't know. It's funny. I don't like. Obviously, there is potentially aesthetic reason, but I actually think the main reason is very obvious, because the function of the gluteals is, from a sports performance perspective at least, is, I think, a lot more clear to people. Having powerful hip extension, that triple extension kind of position, we see it in like lifting, we see it in, explosive tasks. On the surface, it makes sense that there is force being generated at the hip from that gluteal complex. Whereas the adductors, because of when they're placed, because of some of the complex anatomy of it, because of the different portions of it, it's not actually as clear that it's generating a lot of these, whether it's prime movement kind of functions or even stabilization functions, in the same way the gluteals would be. So I think, like, there is that obvious one that you sort of, I think, is on the surface there of, the aesthetic of it. But I actually think it's not so obvious to people what the adductors actually do.
That's actually a good point, because like we often, so it goes back to your point before, Matt, of thinking of sagittal plane movement, where in terms of what you see, the most obvious movement happens in the sagittal plane. There's obviously some people will develop more frontal or transverse movement as a part of their particular movement pattern. Mm-hmm. But it doesn't actually negate the fact that the adductors are not having a very important role in stabilization in that sagittal movement.
Yeah, so a couple of points I'll flag. Actually, interesting you brought up aesthetics, because I actually wrote an article for the conversation a while ago about how glutes just aren't about aesthetics. I don't know if that's why you brought that up.
No,
but,
it's not at all. I hadn't seen the article. I'll have to have a look.
It's good. For our multilingual individuals, it's also written in French.
Do you speak French, Matt?
No, I don't. It got picked up by a French news agency, and they're like, "Oh, can we translate it?" I'm like, "Yeah, sure."
Go for it.
It's probably completely different now.
It probably is. I don't know. If anyone can speak French and read it for me,
I can.
That'd be great.
Very limited.
I would comment. My comment to that would be kind of two part. So from a general population perspective, I agree. Glutes, powerful, strong. People starting out running, training, anything, absolutely, completely agree. But that, I would say, that probably doesn't negate the knowledge or the clinical reasoning aspect associated with an individual that's providing rehabilitation care for that individual. And I'm a firm believer that you need adequate adductor function in order to hit triple extension properly. If you don't have good adductor function, and you're all glute, your leg is going to have a propensity to abduct and externally rotate at the exact same time as you try and hit triple extension, because of that potential agonist-antagonistic based relationship that the adductors have at the hip. Don't get me wrong, it'd be great if it was just a hinge joint and only went in one direction. So that's yeah.
I think one of the things that is very common, and it's been sort of very heavily developed over the last, I don't know, you probably have more of the history than I do, but it was very prevalent, obviously, in the field sports, is the diagnosis of FAI, and particularly the use of radiological assessment for determining, what that presentation is morphologically. what is your current position on where the literature sits with that? Because I feel like that landscape has changed quite a bit in a relatively short period
Short
of
time.
time.
Yep.
Yeah. Where are we currently at with all of that?
So by definition, the diagnosis of FAI involves clinical signs, symptoms, and imaging findings, and that imaging finding is pincer morphology, so that overcoverage, or the more common one is care morphology. From a clinical perspective or from a care perspective, I think imaging should be used as a tool to inform your clinical decision making with regards to how you're going to progress. So I actually had this conversation with people yesterday because they were debating the topic. If someone comes in with clinical signs and symptoms, one person x-rays to determine care morphology to then have that subsequent diagnosis. The other person doesn't. And I probably sit on the side of the person that doesn't as well, because to me, imaging should be used if it is going to potentially change your clinical decision making. So I think that's not just for the hip, that's just for anything. So if someone comes in, they, so 60% of individuals, regardless of whether or not they have pain or they don't have pain, have care morphology. And the prevalence of care morphology is identical between the two. If you basically, there's a really good line in one of Josh Heary's papers, but and I'm paraphrasing, but care morphology merely demonstrates whether or not you played sport during puberty, because the prevalence is the same whether or not you've got FAI or you don't have FAI.
Why do you think we got so caught up in that? Because it went nuts for a while, and there was even people doing really silly things like prophylactically having FAI surgery on a non-clinically significant, presentation.
People without pain.
Saying, no pain at all, no dysfunction really, and they're saying, oh yeah, radiologically you've got changes in your hip. Let's hack into your bone.
That is a very big philosophical question.
Well, you're answering all of those philosophical questions for us. So
that's true. So I would say there's a combination of a few things. Combination of, I suppose, clinical bias to outcome.
Yeah.
I think at times the fee-for-service nature of the Australian healthcare system potentially benefits the provider, not necessarily the patient. We have some of the, I don't know if we still do. I'll check this and get back to you. I'm pretty sure we have one of the highest. Melbourne has one of the highest ACL RICO rates in the world.
Yeah, we spoke to actually researcher Stephanie Philbay last week, and she very strongly put forward the argument that our cultural, at least in the medical world, propensity towards surgery is probably not that well founded actually in the literature that currently even exists now.
Yeah, and I think we do have one of the highest rates of hip scopes in the world as well. However, we don't necessarily have the highest amount of ACL tears or the highest rates of FAI. But I would certainly agree with Steph. She's a very, very, very wise person. I'd certainly agree with Steph on that point. And I think that a combination of, but it's I think it also comes down. Also, there's like multifaceted, the fee-for-service nature of the healthcare system, the propensity for clinical bias with regards to outcomes, the health literacy as well. This notion still exists in Australia that if something comes up on imaging, it needs to be mechanically fixed. But the fact of the matter is the prevalence of imaging findings in people exist with people with pain or without pain. If 100% of everyone that had an imaging finding had pain, and 100% of everyone that didn't have that imaging finding didn't have pain, it's a pretty good justification to fix the mechanical component. But that doesn't exist, as far as I'm aware, for most conditions other than probably your femur sticking outside your leg.
Well,
You know,
yeah,
except for trauma.
let's say
Except for trauma.
exactly.
Yeah.
Yeah.
It's an interesting idea because it's one of the biggest challenges that you face as a clinician, actually, who is up to date with the literature, is that you're commonly trying to educate people into not over servicing, things like radiological investigation, surgical opinions, when you've got the up-to-date literature that says that a surgical opinion is not helpful for the condition that they're presenting with, yet they want to go to that clinician and then get an answer that they end up coming back and the person says, no, you're not a candidate for surgery, go back to rehab.
Yeah.
Which is good from the people that we work with and we refer to, but it's often very difficult to educate people on that stuff. And I think that's one of the key challenges that we have at the moment for people and good clinicians who I think are actually trying to educate the community on what is current best practice.
Agree. Completely agree.
One of the other articles that you've published that I found quite interesting was looking at exercise prescription in physiotherapists in Australia.
In the world.
In the world, okay. Which I think is particularly interesting.
Don't cut him short, Jack.
Yeah. Just so you're aware, I need to, full credit. I was brought on to this project because I am a maths nerd. This is some work done by Christian Barton. It was driven by Christian Barton. He designed this, put this all together with his team, and I was brought on because I'm a bit of a maths nerd and a bit of a data geek, which is great, and I love that sort of stuff. So when Christian came to me and said, "Do you want to work on this?" The subject matter was sensational. The power of the data set was sensational. I was like, we need to really delve into this.
Well, yeah, I think it's particularly important at the moment because we're seeing such a transition of physiotherapy, at least in Australia and other parts of the world, towards exercise prescription. And
which is good.
It certainly has its value. I mean, I think it's an interesting conversation to have.
There's some limitations to that too, which we'll
absolutely
ask you about.
Yeah, but I think one of the things that was evident from that article is even though that's prevailing, there's a lack of confidence from a lot of clinicians in their knowledge of exercise principles and therefore their ability to prescribe different types of exercise interventions based on the presentation and what needs to be actually developed. And so this raises an interesting question. I think this is actually a good question for you too, because you do work both as a researcher, but also in the teaching environment of what are the things that you think we're missing with regards to teaching physiotherapy students to ensure that they actually have adequate understanding of exercise science principles?
Yeah, so it's a good question and can be a multiple day discussion. I will say this about that particular paper. The individuals, I've got to hang on, just let me get my year right here. The individuals that had the greatest knowledge of the exercise principles, as well as physical activity guidelines, were the ones that had graduated from their course in under 5 years. And when you compared individuals that had postgrad qualifications versus those that didn't have postgrad qualifications, they weren't any different. Now, in saying that, that is any postgraduate qualification within the physiotherapy space. So someone could have had their postgrad someone could have done this survey, had their postgrad in pelvic health. And that certainly was the case for some people, because some people listed rehab guidelines for post-pelvic surgery. So there's a whole, everyone from Musk to sports to pelvic health people would have been involved in here, but the ones that had the most amount of knowledge were the ones that had graduated within 5 years. And actually, the knowledge, unfortunately, the knowledge got a little bit progressively worse in some instances as time from graduation increased. So this, I think we've all had it. We've all worked at relatively large clinics in the past. There's people that wind up and just always want to see the scene. Oh, you haven't? No.
John's got a very unique path since
That's
he graduated.
That's fair.
He figured
always
out pretty early on that if he was going to be a physiotherapist, he'd have to do it his way.
Yeah, that's fair. That's good. That only want to see, that won't see, will go through everyone's profile and won't see the clinician that says they graduated 2 years ago, which I think is somewhat, based on this, is at least somewhat unfounded, because their knowledge base is there. In fact, their knowledge base is strong. So why? I think. Why is it the case? I think that there are multiple factors. I think that there are components with regards to legislative requirements of what needs to be in a course and what is optional to go in a course plays a little bit of a role. I think that there are sometimes potential issues around resourcing and redevelopment. I think that there is also a component. I think the profession as a whole, Musk and sports wise, I don't say loggerheads, but there's, I suppose, the slightly newer physios that are more propensity to exercise prescription and physical activity, and then there's potentially some other physios that do heavily lean on their manual therapy skills, and what manual therapy could be or should be taught and what isn't taught, and what exercise should be taught and isn't taught is a whole. As you can see, I'm clearly sitting on the fence with regards to answering that question.
Well, why?
Pardon?
As the great old El Paso says, "Por qué los dos?" Why can't we do both? I don't understand this.
I agree. Why can't we?
It.
I agree. Why can't we do both?
And why can't we be good at both? Because I think that's the differentiating factor for our profession, particularly in a place like Australia with such good training and such stringent standards to get in. I think the frustration that both Jack and I have, particularly when we have students who come and visit us for placements and things like that, and they're being heavily pushed towards, and I'll be open, like as someone who's not involved in the university structure, they're being too heavily pushed towards thinking that exercise is the only modality because the quality of research is better in that field. Mm-hmm. However, they are undermining a whole area of the profession that they don't really understand very well, to be honest, which is manual therapy. A lot of them don't have manual skills, and they don't even understand a lot of the literature on it. Some that lacks, some that doesn't. But it's really interesting to me because, and this is a personal position, obviously, but we should be good at both, and we should be able to use both for what they're good for, and then not use it when it's not appropriate.
I agree. And I think there's extremes on both ends of that particular spectrum. I guess my personal opinion in and around that space is and this probably is my TAC and public funding background, coming out here. I would, and unfortunately, I've seen a lot of cases whereby there's been a heavy reliance on manual therapy, and that subsequently doesn't promote an internal locus of control or increase someone's
totally.
self-efficacy. And my internal struggle that I have is fundamentally, to be honest with you, comes down to this is probably a public health statement, but who's paying for it? So if people are paying for their own stuff, they can do whatever they like. But if we know an intervention has a good long-term outcome, we should be helping promote and push that particular intervention over another intervention that may not demonstrate its long-term outcome, particularly when it comes to public funds.
I think the thing that is hard for people to get around, and it's something that Jack and I talk about a lot, is we know that for manual therapy, the evidence supports that it being a transient,
transient agent to help improve. Yeah. No, I agree.
And as long as you see that, and you know when it may be clinically appropriate or not, it doesn't mean that it's not an important part of someone's process, whether that be in a public setting or not. It's just that you need to understand that it may only be a small portion of what you do in the early part of their pain management. That's not going to be an ongoing intervention that you feel is going to make the long-term changes for their recovery.
Yeah.
And it's not to say that it doesn't help. It's just it's only going to be used in a certain context.
Yeah.
So I agree wholeheartedly with that. I would say that at times, not everyone uses manual therapy that way, though.
No, that's 100% true.
I think the other part of this too is like you were saying in that article where the older the physios who graduated more recently had a higher knowledge of exercise
Prescription and
recommendations.
principles. Yep.
Yeah. On the other part of that is the older physios would be much more effective at manual therapy. I would make the assumption, and I think just
you develop your own bias of what you're good at.
Totally.
Yeah.
And I guess that issue too of, if all you have is a hammer, everything looks like a nail.
Yeah,
That's
yeah.
the other issue too, because I think that's one of the things we see with the younger clinicians who come into our clinic is they're actually not confident to do manual therapy because they're actually not familiar with the different types of techniques and when you may do one particular method over another.
So in the paper as well, so we cover exercise principles, but we also cover physical activity and knowledge of physical activity. And this is obviously part of a larger suite of work that Christian works in around, promoting health and promoting physical activity. For physical activity in itself reduces the risks of at least 35 non-communicable diseases. And I think there's a really good document. Actually, Christian is in this. There's Q&A. What's the ABC show where there's like a half circle and they have all these guests and the people is that Q&A where people can ask questions and talk?
It's either that or Insight's the other one.
Or Insight, yeah. It's one of those TV shows, and a surgeon goes, if you could pack the health benefits of physical activity into a pill, it would be the largest grossing drug sale of all time.
We actually did a podcast earlier today with Mark Matson, who is
yeah,
which was actually fantastic. And
just guys rock podcasts out left, right, and centre.
Got to keep busy.
It's good.
Absolutely.
It's good.
But
who's man in the clinic?
But we were talking about this very thing of the power of exercise and the attempt to actually try and create a drug to upregulate the molecular or cellular pathways associated with exercise, but it actually not having anywhere near the same effect because of the fact that exercise is impacting multiple systems in multiple ways. Yes. Yeah. And I think it's interesting because part of the question I often ask myself is thinking of exercise recommendations versus principles, where principles allow us to be able to manipulate variables to optimize the outcome for the individual. But I also think the recommendations are a useful thing, particularly in the general population, because with a lot of conditions that people present with that are associated with musculoskeletal problem, i.e. like non-specific back pain, neck pain, even things like OA, how much benefit they actually get from the systemic stimulus of physical activity itself. And as a result, where is their level of physical activity now? And are they reaching that actual baseline?
Agree. I look forward to listening to that one. That's good. So it leads me towards one point. Like the knowledge and I obviously haven't listened to the podcast, so I'm just obviously giving my 2 cents on one sentence. The knowledge or drive to basically create a pill that would have those benefits just demonstrates a promotion of what is a relatively low amount of like self-efficacy and an external locus of control. Like I want the quick way to get the benefit.
And look, part of this is reflective of the fact that to create any adaptation requires you pushing yourself out of your comfort zone. And unfortunately, one of the limitations of humans is if we can take the opportunity to not do something that's uncomfortable, we'll take that.
You're telling me, mate, I take the lift 5 floors up to my office and get yelled at every day by my colleagues.
On this topic, it's interesting.
Me taking a lift.
No, not you taking a lift. I appreciate that. Is the interesting part is, as Jack was mentioning about the principles of the individual and even probably individual environments. So one of the things that we often ask the question, and it's us being smart asses, to a student who's trying to prescribe something that is exercise based to someone who is very athletic, for instance, where they're more than meeting the recommendations, and actually the physical stress that they're being exposed to is being driven by the fact that they're actually exposed to so much physical stress over time with their training or whatever. And we say this in light of understanding that we often work with a very niche population, particularly high-level athletes. But it puts forward an interesting idea around the principle of understanding if you already have an individual with a huge amount of physical stress that you've imparted upon them, what is the intervention that you're going to put in place that actually is going to assist with whatever presentation they've got? Because ideally, you don't necessarily want to add more physical mechanical stress to their system if that's the thing that's actually driving a lot of the presentation in the first place. And
agree.
A lot of students, often the smart ones, work it out really quickly. They go, oh, actually, maybe we need to remove some stuff. If I don't know if you're a fan of any of Nassim Taleb stuff, but he talks of, via negativity. What do you actually need to remove from this equation rather than add to this equation in order to get a good outcome? And I think about that a lot when I talk to students of, we have this mentality, I think, as clinicians in general, and it's a bias that we all have no matter what profession we're in, where we want to be able to use our skills to help people. And that's coming from the compassionate side of us. But sometimes we need to recognize where the skills that we have are actually, there's no thing to add. In fact, we maybe even need to remove some stuff. And that's probably more of a general comment. But I feel like it's one of the things that maybe isn't discussed enough of, when you're dealing with a patient, are you actually recognizing what's driving this? And if you are, is there a time where us as a clinician actually needs to remove certain things?
So I agree. Like, what is your intended outcome, and what is the purpose of that outcome, and how does your decision either way facilitate that outcome or potentially inhibit something else along the way, regardless, independent of whether that be altering their current training load, rehab progression. Oi,
Yeah, someone's got
their motorbike going.
Motorbike.
Yeah. And I just lost my train of thought because of that. So I also think it's around clinicians being confident in understanding their limitations.
Yeah,
and I think
massive, isn't it?
Yeah, I think that does take a little bit of time to develop. And I think that in itself is a skill. There are people more qualified than me and have much better knowledge to deal with multi-sport and long-distance athletes than I am. My background and my treatment background is in strength and power and rugby. So I'm used to dealing with big people, strong people, not long-distance runners, not multi-sport athletes. So I think it's also about, I may not be the best person to help you achieve your goals, but this person certainly will be, and then subsequently facilitating that. And I think it's, from a young clinician perspective, I think it's they want to help everyone, like they want to fix everyone, but sometimes you can't do that. You need to understand your own limitations associated with that. Just like I think when clinicians come out, they have to get a diagnosis 100% right on day one. I'm like, it's okay to say to a patient, it appears there could be a few different things going on. It could be this, could be this, could be this. Let's try this first. It's definitely that this will happen. If someone's not progressing the way you should be, something else is potentially going on. You need to delve into things a little bit quicker.
And I think more broadly then too, of appreciating and understanding the known unknowns, because it's like, to expand on what we've been talking about, of doesn't have to be just about manual therapy or exercise or doing more physical activity. It could also be less. But then I think also too, considering that it may not always be related to those physical and mechanical parameters when we think about other stresses associated with the development of pathology or injury, when we think about things like sleep, like diet, like psycho-emotional stresses as well. And sometimes these are things that may be outside of your scope of practice, but being able to actually identify them as a key element to their actual success of a good outcome.
Yeah. I remember a patient from a while ago, ongoing, was a volleyballer, had patellar tendinopathy issues, PFP pain as well, had been bounced around for like 4 or 5 years, multiple injections, multiple this, multiple that, a couple of surgeries, and came and saw me. She got referred. She went and saw someone else, got referred to me, and I was like, she had all this stuff, and I was like, you know what? Just don't do anything for 3 weeks. She's like, what do you mean? I'm like, don't worry about any rehab you've been prescribed. Don't worry about anything. Just do nothing and let's see what happens over the next 3 weeks. She got 40% better in 3 weeks without doing anything. And I was like, well, maybe she's just been doing a little bit too much of everything. It was, it was good. It's like I tell people when they deal with like lateral hip pain, and they're usually, postmenopausal women. They get, lateral hip pain, greater trochanteric pain syndrome. Like I talk to people about it, I'm like, at a minimum, get their bum higher than their knees and stop them crossing their legs, and start with that for 2 weeks, and you'll be surprised. It'll take off it'll give you a fair chunk of change. So sometimes the littlest things can help.
I was just did you have a question to ask, John? I was the last question I was going to ask you is there anything interesting?
The last one's always hard.
What's your deepest, darkest secret, Matt? No. Is there anything in particular that you're exploring or learning at the moment of interest that's interesting to you or that you're excited about?
It might be physio related, it might be completely unrelated, but you're having fun exploring it.
Oh, that's good. Well, my joke answer would be I've changed my grip with my driver at the minute, just trying to. So from a work perspective, from a physio perspective, I've actually started to jump into a slightly different space, and I'm currently in the process of helping co-design and develop a digital care pathway for patients that present to ED with back pain. And looking at, I suppose, their symptom trajectory and also their, recurrence for ED presentations. So really enjoying that because it's not in my usual, it's certainly not in my usual knowledge base of things, delving into the back pain literature. I suppose I kind of landed in that from a data perspective, but I'm really enjoying working with new collaborators, some new people, a new topic that I haven't delved into. They have taught the team have taught me stuff that they commonly do, and I've taught them stuff that I've commonly do or that I've learnt from my hip stuff. So that's good fun and interesting. From a personal perspective, it's a bit weird. I'm trying to learn how to smoke meat. Would you accept that as an appropriate answer?
I'll have to get some off you next time, Matt.
But I'd hold off for a little while, actually.
Has Jack given you any of his beef jerky?
No, he did try once. He did try.
It's very good.
I can't remember if I've given you any of the beef
jerky. No, you haven't given me any. I'm not a massive beef jerky fan.
Oh, you have to try this, though.
Yeah, it's pretty good. It's not like the stuff you buy.
Well, don't buy any of it. That's the problem.
Well, that's the first problem. You should be buying some.
Next time I'm in Latrobe, I'll be sure to bring some in at some point.
Yeah, it'd be good. But yeah, I'm assuming you asked that question to everyone.
We do.
Yeah.
We get some good answers, actually.
Yeah.
Right.
My plan for this year is to learn how to surf.
Nice.
So, but I haven't got that.
All right.
Yet.
I think we won't hold you up any longer. It sounds like you're extremely busy.
It's Friday. I'm going home.
Yeah. Thank you so much, Dr. Matt King. It's been a pleasure talking with you.
Thank you very much, gents. It's been great.